all about in feminine. Okay, I guess I'll start again. Hi, Cheryl Whitman, Beautiful Forever. And I have a great guest with us today. And we're going to talk about the new trends in feminine rejuvenation and women's sexual health. And we have one of the top experts. I guess it's like 25 years. We know each other probably 7 or 8 years. And I'm really excited to introduce to you today, Dr. Troy Hailparn. And we'll tell you more about her as we move forward. But stay tuned. Any questions you have, there's courses that doctor gives. There's lots of great information. So get ready to take some notes, ask some questions, and we're happy to present for you live today information on women's sexual health and how to add it to your menu. We also offer mentoring programs for coaching, support, guidance, which is very important, whether you're starting out or whether you're expanding, whether you're going from, and we'll talk about this in a minute, from insurance-based to cash-based business. Everybody needs some mentoring and consulting help. So we have a limited number of spots that we take monthly for people that are starting up. And then also we have another section for those of you that are expanding your practice. So contact us, love to hear from you and be able to answer any of your questions, and happy to move forward with you. Well, there we have a great picture of you, doctor. So we have our cosmetic gynecologist from San Antonio, Texas today, Dr. Hailparn, and she is here to tell us lots of great information, what's going on globally in the world, because she is actually a renowned cosmetic gynecologist who does, I would say, 25 years worth of vaginal rejuvenation, women's sexual health, and works on the whole person. Her background is extensive, and she was one of the first, which is very impressive, female board certified OBGYNs in the US taught laser rejuvenation from the Laser Institute. And there's lots of things that the doctor has to share with you today that go way beyond her bio. And I love the fact that she's worked with over 3,000 women and vaginal rejuvenation and nearly 900 more of the surgical procedures, with about, I don't know if it's 22 or 25 years by now of experience in this industry. So I'd like to introduce Dr. Hailparn to you, and we will have a great discussion today, and I'm looking forward to it very much.
Well, good afternoon, everybody. I hope everyone's enjoying the day, and I look forward to speaking with you on these wonderful topics.
And, you know, I love the fact that you're willing to share your pearls and things that you've learned, and you're very upfront about it. And feminine sexual health is the way you present it, which is great. And I know you went from insurance to cash-based business. So tell us about that transition and how long ago that was, and would it be different today versus when you did it?
Well, my transition started in 2003, actually, which is when I made the decision to expand my knowledge about women's health care. What I found after doing a dozen years of OBGYN is that women weren't getting all of their issues addressed properly, and insurance wasn't covering all of the concerns. And I was at a point where I just wanted to change what I was doing and focus on surgical. Surgical really fixes things. And now, of course, we have a whole bunch of non-surgical tools in the toolbox, which are a wonderful adjunct. So I think that the transition was hard. Going from an insurance-based practice where you have patients scheduled, calling you, sent over from the insurance companies. I used to be booked 7 months out in advance. And when you change over to a cash-based practice, suddenly your whole business model changes, because you have to learn how to market yourself and how to get onto social media and have to learn a whole new way of doing things. And a cash-based practice is not a guaranteed practice. It's day by day, week by week, month by month, as things grow and expand over time. So it certainly was a transition, and it took a few years to transition my practice. And my focus on women's sexual health has really been for the last 15 years, because both damage from childbirth and issues related to labiaplasty, both the inner and the outer lips, really don't get discussed, and women are not educated about some of those aspects of their sexual health.
No, I think what you're doing is great. And I think that people are willing to pay you so they could get fixed in one way or another. And women can become women again and feel good about their sexual health. And the other thing that comes, well, I guess, you know, when we met, it was probably soon after that when you started with Thermiva. And you probably remember those days.
Yes, 2015 is when I started using radio frequency in my practice, and it really made a big difference. I'm a data collector, so I give questionnaires to the women who come in before their treatment and after their treatments so that we can see the success of those treatments. You know, did we achieve what we set out to do? Did their incontinence resolve? Did their lubrication improve? Did their orgasmic response get better? Did they feel tighter? So all of those things I've been documenting, and for over 220 women, I've had an 86% success rate in treating the functional aspects using radio frequency and 96% improvement in how the appearance on the outside looks. So
That
it's
would be-
been a great tool.
Yeah, and that would be a great white paper for you to put together or a case study. I think that would be wonderful. We should talk about that because I think that information and that data is very important. And so now, okay, now you're settled, you're in your cash-based business, you're really busy. So tell us about how COVID affected your business and this post-COVID boom that we've been talking about.
Well, really in 2020, like a lot of businesses, my practice was considered elective, even though the women who come to me would say it was not elective, it's functional. But so for 6 weeks, my office was actually closed. But when I reopened, I had a deluge of women calling and wanting consults and wanting to address their issues. Their quality of life's been affected, and now they're working from home. So I actually had a very busy year between the mid 2020 to the middle of 2021, because everybody's trying to get their lives back and put their bodies back and recover while they can from home. So it has been a busy year, and it's felt very good because so many of these women have had issues that haven't been addressed and have been living with problems for a long time. And so to restore their quality of life and their function, it's rewarding, not just to watch them do well in their lives, but for what I do.
And you're very passionate for what you do, which comes across now and it comes across whenever we've talked or met in the past. So what really makes you unique in San Antonio, Texas? And I'm sure people come to you from, you know, surrounding areas or surrounding states. So what do you think really attracts them to you? Because there's a lot of gynecologists out there they can go to.
Yes, there are. Well, I've been in the field since the beginning of cosmetic plastic gynecology in the early 2000s. And so I have probably some of the most experience, especially among GYNs in the country, doing these cosmetic plastic procedures. The other thing is I teach other doctors because I feel like there isn't good training and residency programs. I'm sorry to say, and I wish it were different, but we learn how to do D&Cs, and women doctors can choose whether or not they want to do an abortion or not. But if somebody comes in hemorrhaging, they still need to know this procedure. And if doctors are hesitant to learn labiaplasty because the American college thinks we are going to do it for cosmetic reasons, they're really missing the fact that in development, estrogen stimulates the labia to grow. They become problematic for women, and we should be able to take care of that problem. Why should they go to a plastic surgeon who has no familiarity with female anatomy? And here it is, we work with it every day. So I really think that they're missing they're not understanding the need for physicians to learn this. And so I'm here to offer that knowledge, not only to women about their bodies and why they're having the symptoms they are and what their options are, but so that physicians can become better at what they do. And not only do they need a didactic course, but they need proctoring. They need to have somebody sitting next to them in the operating room directing their hand to get the best experience. But those are what makes me different. And then in terms of patient care, a consult with me is 1.5 to 2 hours long. I will give sexual function questionnaires to help assess what is going on with that woman at that moment in time. And I review those. I review a pelvic model. I also go over before and after pictures of many different surgical and non-surgical procedures. And so they can see differences in anatomy. And then when I do an exam, I provide a mirror and we go over their anatomy and why they have the problems they do and how the different options can help. I listen. I hear the women when they say, this is hurting me, this isn't working for me. Constipation, hemorrhoids, tampons not staying in, those are things that women don't talk about and doctors don't ask about. But manually having to assist in going to the bathroom, that's almost taboo. But many women have this as a consequence of childbirth. And if we ask the right questions, which is what I try to do when women come in, it really lets them know that I understand the problems that they have because I'm asking and I'm also offering solutions. So that's what I try and do. I try to listen, I try to assess, and I try to offer options to these women and educate them about their bodies and what can help.
I mean, an hour and a half or 2 hours of your time is very valuable. I think you listening and you learning about the patient is, I mean, I don't even know. What do you charge for a consult?
A consult is $175, and that goes towards whatever procedure they decide to have if they follow up with that.
Well, I think that's very fair of you and your time and what you're doing for them because you're changing their life. I mean, I hope you have videos of women saying, you've changed my life.
I certainly have written testimonials. realself.com and Google have a lot of testimonials from patients on them. So yes, I would love to actually get a group of my patients together and have them be interviewed by somebody other than myself about their experience, because so many women have the issues related to childbirth, which are bladder, bowel, and sexual function. And insurance will cover the bladder and bowel stuff, but not the sexual function. If you go in and tell your doctor, I can't feel my partner, he's falling out, there's air that's embarrassing, the number one response is squeeze your muscles. And I have to say that's the biggest lie women are told. And I'm going to show you why. Don't laugh, but I'm going to use a toilet paper roll. And this is to mimic the birth canal before delivery. And after delivery, the back wall is primarily impacted and it separates. So the tube is no longer a unit. You cannot effectively squeeze these muscles when they are separated or thinned out. And I have women that have come to me saying they've been squeezing their muscles for years. And my first response is, what a waste of good energy. If it doesn't do anything after 3 months, it's not going to do anything. And you need to be reevaluated for the back wall support. So just so women know, this is a myth. Do not waste your time squeezing your muscles. Get reevaluated by somebody who has a better understanding of what your functional problems are.
So the Kegels that everybody talks about, you're saying that if they don't work in 3 months, then just give up.
Then look for other options to help
Right.
fix your problem. Okay. So like women who have stress incontinence is related to delivery, aging, weight gain, and it has to do with downward pressure on the bladder neck. Okay. So if somebody loses 10 to 20 pounds, they can improve those symptoms by up to 50%. But nobody counsels women on weight loss and having a positive impact on that kind of incontinence. Women in their 40s can benefit from vaginal estrogen because the bladder's an estrogen sensitive organ. So adding a little estrogen may improve the leakage. So there's other ways to address it. Women who drink a lot of caffeine don't realize that caffeine is actually the bladder's enemy. There is a little muscle in the bladder wall shaped like a triangle called the trigone. And caffeine makes this muscle spasm, which gives women the urge to go. So we're actually creating the urge in ourselves. And secondly, caffeine is a diuretic and dehydrates our body. So for every cup you drink, you pee out 2. And if you're drinking venti lattes and things like that, imagine how dehydrated you really are and how much time you spend running to the bathroom. So that actually will worsen incontinence because you now have a rush of fluid going to your bladder and you're stimulating that muscle. There's another kind of incontinence called urge incontinence, which is when you get that urge to go and you leak urine. versus just having the urge all the time, which is an overactive bladder. And reducing caffeine can help with both of those. And so can radio frequency. Radio frequency is a great non-medicinal option to treat the overactive bladder. A lot of times women will be offered medication for that, and they cause insomnia and constipation and dry mouth. And who wants those side effects if you can address this without medicine? So radio frequency is a great option for the stress incontinence and the urge incontinence.
So if you do the radio frequency, I could go back to my coffee and tea.
Well, let's just say a cup a day is okay. All right. But if
Okay.
you're drinking it all day long, you're going to have a negative impact on your body. So, it can also help with hypertension, because obviously when you drink caffeine, it brings your blood pressure up. For women who need to be better hydrated, just by reducing the caffeine and drinking more water can be truly helpful to their body. It will help alleviate some of that constipation they might be having. It can help with dryness during intercourse. If we're not hydrated well, it can affect other parts of our bodies and we don't even realize it.
You're right. I don't think people really do realize that. And talking to a lot of professionals like yourself who are not as knowledgeable, they don't go into any of this with their patients at all. I mean, I know gynecologists I personally have been to, you're lucky if they stay in the room, 5 minutes and then talk to you for 5 minutes afterwards. So you're really doing a great deed to many women. And this is obviously something that that women need to learn about, because, women, as you said, don't talk about it necessarily. And then they go to their doctors and the doctors don't talk about it. How can we get women to start the conversation and start to talk about it with their physicians, or the opposite for those that are listening who are providers? How could they get their patients to start talking about it?
So one of the things that I do, and it may be helpful for others, is I have an intake questionnaire. Now I have it electronically. I used to have the patients sit and fill it out when they come in, but I ask specific questions about bladder function, bowel function, sexual function, and their labia anatomy, and if they're happy with the appearance or if it's causing any functional concerns. And I think having a basic questionnaire that they can fill out, then you're getting that information without spending the time asking all the questions. You can read through and you can see exactly what their main concerns are, and then the visit can be focused on those concerns. The problem with insurance-based physicians is that their time is very limited, and what they can do is dictated to them now, which is one of the benefits of being in a cash-based practice that I truly, truly love. I don't have to spend 5 minutes per patient or 10 minutes a patient because they're here for this problem or that problem. I will look at the whole person and try and help that person achieve a better quality of life, as well as addressing the specific concerns that they come in with. But you come in for your annual, you get a breast exam, a pap smear, here's your prescription, and they don't have time to talk about your sexual function or your labia. If women have the courage to ask their doctors about labia, most of them are going to say you're fine, and why would you want to do that? Or you don't need anything. And they're not listening, and they have no understanding of the labial issues and how they're impacting that woman's life. And that's truly disturbing to me, because this is a gynecologic problem. And so many GYNs are just not educated about the labia, even to have conversations. So I will say that I do have, published by ACOG, an online e-module for my colleagues. It's 110 PowerPoints slides, and it's, I think, $70 or $90 for CMEs, 9 CMEs. And it's truly an education about the development, the issues that come up, non-invasive options, surgical options, and how to have these conversations with the patients, and to give the doctors a better understanding of the surgical options available. It doesn't teach them how to do a labiaplasty, but it gives them basic knowledge to have conversations and to know who to refer to if they believe their patients truly need something. But a lot of times doctors will tell women they don't need them, or they have other things to worry about. I had a morbidly obese patient go to her internist, and her labia were at least 4 to 5 centimeters in each direction, chronically rubbing, bright pink from irritation. And she asked her internist about labiaplasty, and she was told she had more important things to worry about, like hypertension and diabetes. And this patient didn't bring up labiaplasty for 5 more years after that. And imagine, had she had a labiaplasty, she'd be able to exercise and lose weight and become a healthier person. So this internist didn't even understand the impact that this was creating on this patient. And that's really where it hurts my heart, where so many women are just ignored and not offered solutions or referred to the right people, or who live with these problems for years and years before they finally hear about it on the internet or read an article about it, So it's important to get education out there for all of these issues, the childbirth and functional stuff there, and the labial issues, even things like lichen sclerosis, which is a dermatologic condition women get that can affect the vulva. It can mat down the clitoris and affect orgasms. It can cause fissures and cause painful sex. And the wonderful thing is that radio frequency can treat lichen sclerosis. And so can platelet-rich plasma. That's also called the O-shot. A platelet-rich plasma has been used in sports medicine for the last decade for joints to help reduce their need for surgery, and it helps with injured tissues. And so this can be used to help treat as well, to make those tissues better integrity and help the symptoms go away. So,
and I think that brings up the controversial stem cell therapy and the O-shot versus the G-shot. So now that you told us a little about the O-shot, I think tell us the G-shot and where you stand on that, and how the stem cell therapy, I guess in a little bit more detail than you just went into, would be beneficial.
Okay, so first of all, years ago, when I first started learning about these procedures, the G-shot was being offered. The G-shot is collagen. And imagine if you're going to inject an area that creates orgasms, what collagen might do to that spot. The premise was to enlarge the surface area. So if this spot existed, it would be more available for stimulation. The problem is, for many, many years, there's been nothing to identify any anatomic structure in the anterior vaginal wall. It's true, it has increased nerve endings. And it's true, if you stick your finger up there and feel around, you might find a spot or two that has increased sensitivity than the rest. But the reality is we have erogenous zones all over our body, the backs of our necks, our inner thighs, our nipples, our stomachs. So, skin is the largest organ we have. And so we should take advantage of that, first of all, in terms of sexual stimulation, and knowing that it's there and can be wonderful. But not everybody is clitorally stimulated. Not everybody is vaginally stimulated. So, and some women are lucky enough to be both. So some women will come in and say, I've never had a vaginal orgasm. I want to have one. And their expectation is perhaps that the O-shot or the Thermiva can give them that. And that's not a real expectation. You have to.
Okay, so the expectation is that we need to get Dr. back to let's talk about it. And the stem cell therapy is controversial, but is being used in many areas, from orthopedics to aesthetics. The amniotic fluid is being used. There's lots of different stem cell therapy. The one she was referencing was PRP, taking your own blood and spinning it and re-injecting it. So I know that there's controversy with that, but the doctor's back and she will tell us about the controversy that we left off at.
So sorry, I lost my connection.
Okay, sorry about that.
I am back. I apologize. So anyway, the G-shot, I would not recommend, okay, because there's no formal G-spot to inject it into. So that's what I wanted to just wrap up with that. Now, in 2012, Professor Ostrinsky published a paper, and it was the #1 read paper in 2012 on a new discovery of an anatomic structure in the anterior vaginal wall that happens to be a neurovascular structure. And I have a colleague who went also and followed in his footsteps and validated this anatomic structure. So there's actually two articles, one saying it exists and the second one looking at the histology of it. And it is actually, like I said, neurovascular. So let's say this is the pacemaker of orgasms in the vagina. And this is hypothetical, we still don't know. But again, would you want to inject collagen into something that has vessels and nerves? Probably not. It would obstruct it and desensitize it. Now, the O shot is platelet-rich plasma or concentrated growth factors. If somebody who was orgasmic becomes inorgasmic, then you need to evaluate the whole person to figure out why. Is it anatomic? Is it hormonal? Is it blood flow? Is it the brain? Is it the partner? I mean, if you're not being stimulated mentally by your partner, the physical part's not there either. So, so that's really important to understand. But these growth factors can, in fact, help injured tissue. And I've used it to treat recurrent scar tissue, scar bands at the vaginal opening, painful scar tissue inside the vagina. And it can also help around the bladder neck for supporting it. So for stress incontinence, this can be helpful for some women. And used in conjunction with radio frequency, what they call Thermi-O, the combination of the two enhance each other's results. So you can get greater results when both are used at the same time for orgasmic dysfunction or for the lichen sclerosis. And it's amazing when you can combine these therapies and really help quality of life and pain and incontinence and things like that.
How many treatments does it take when you talk about the Thermi-Va? I don't know if things have changed in the years since we started using Thermi-Va, which was 3 treatments.
Yeah, so this is the wand. This is the wand. It's the size of my finger. It's not like an ultrasound probe. A lot of women have a misconception. And let me just say one thing. Women don't understand the differences between lasers and radio frequency. And the most important difference is lasers destroy cells to rejuvenate them. And radio frequency stimulates the cells. So it's a non-ablative tool. And that's what I like about Thermi-Va, about radio frequency the most, is it's non-ablative. There's no downtime. There's no funky discharge. The risk for burns is almost none. You don't need any special equipment like glasses and signs on the door. And the lasers sometimes need 2 pieces for the inside and the outside. They're not able to do both with one instrument, and this can treat the inside and the outside. And so, it has a heating element on this side, and the way it's used is kind of like ironing. It's gently inserted with lots of lubrication into the vagina and moved back and forth like ironing to distribute the heat. And the heat does 5 things. It increases blood flow, so it wakes it up. It stimulates nerve and blood vessel regeneration. It stimulates protein production, which draws moisture in. And this is a really good thing for women who have dryness causing painful sex, especially those who can't take estrogen or who are smokers, who have blood disorders or are non-surgical candidates, but this can truly help make it come back to life. It helps with orgasmic response as well, and it tightens existing collagen and stimulates new collagen. And by doing that, it does increase sensation and help support the bladder. So it can reduce leakage, calm down that overactive bladder, treat dryness, help with orgasmic response and sensation. But it takes 3 treatments, roughly 4 to 6 weeks apart, and then a maintenance treatment, just like with Botox or Juvederm or any of those things, about once a year. Now, the results are dependent on your body's response. Okay, your body makes collagen and increases blood flow in response to the treatment. If your nutrition is poor, if you're older, you may need collagen supplementation. So it's important to understand there's other factors that can affect your response. And you may come in with 5 problems and it may treat 3 of your 5 problems. But everybody gets an improvement of some sort. It's just, will it be enough to treat your issues for the long term? And then the maintenance treatment is just once, and it's usually once a year. It could be at 9 months, it could be at 18 months, depending on your body and whether you want to come in right when the symptoms start to return or a little bit before to prevent them from returning. So it's great to have the platelet-rich plasma, the O-shot, and radio frequency. And the other option we now have is stem cell therapy. So Amdrop is one of the forms stem cell therapy comes in, and it's a small volume of liquid that are undifferentiated cells. And this, again, stem cells have been used in sports medicine for years. They get injected into the injured areas and they help them heal. And sometimes they don't need surgery. And so I've used this several times to help with that overactive bladder, to calm down that urge. And I had 2 patients with interstitial cystitis, chronic bladder pain that many other doctors were not able to help. And the injection of the stem cell therapy around their bladder neck was helpful in alleviating their pain. And that is a case write-up. And I haven't done that yet, but having 2 patients that it's helped really is exciting. And if you go onto the amdrop.com website and look in the urogynecology section, it talks about how this can help the urge and overactive bladder. So there is information online. It is not FDA approved stem cell therapy and is still considered controversial, but we know clinically it helps, just like we know clinically bringing the muscles back together and restoring the back wall function of the vagina helps with sexual function. We know that this also helps with bladder function. And so it's just a matter of having enough data over time and submitting it and having it evaluated so that these things become available for everybody.
Which is great. And the age range, it's interesting because it used to be, oh, women that perimenopause, postmenopause, they're your target market. But it has been different than that. So maybe we can hear from you, like the age range, which I know is expanded in time.
Well, for radio frequency, my oldest patient was 84 and my youngest patient was in her 20s. And so there's a big range. Women will come in after having children, and women are having children in their 20s and their 30s. So when they start to have some changes in their body function, they're exploring ways to address it. And many times if women have several children and they're working, they don't have the downtime. And so using radio frequency is great. It's a 20-minute treatment. They can come during their lunch hour and go back to work with a smile on their face, or, they can come in anytime, but they can go back to work, exercise, have sex the same day as their treatment. So that's a really wonderful thing. And with lasers, usually you have a few days of downtime.
Yeah, that is very true. So how do you get the word out to new patients? Obviously, you have a database of people that are coming back to you for maintenance and so forth. But how do you get the word out? And what would you recommend the best way? Because everybody puts out ads in social media, and there's events and there's virtual events, and there's so many multiple ways. And I know that you've done them all. So tell us where your success has been.
Well, I have a wonderful website and I try to update it periodically. And it used to have a lot of information and a lot of articles, and it still has a lot of information, but I've honed it down. And I think it's really important if people Google vaginal rejuvenation or labiaplasty or vaginal tightening, they can find me that way. My website is cosmeticgyn.net. And that's really the #1 way women find me is Google, and then Real Self. Realself.com is another wonderful website where women look for all kinds of plastic surgeries and cosmetic surgeries. And there's surgeons all over the country on there with their profiles and their before and after pictures. And so that's a really good place for reading other reviews and seeing the doctor's work. And then my referrals have gone up significantly over the last few years. Referral from other patients, referrals from friends, and referrals from my colleagues, which is really wonderful because at the beginning, people were very skeptical. Oh, what's she doing? They don't know. And of course, without having the knowledge and without asking, because a lot of people don't want to ask, what are you doing? It's so funny how things can develop. But the reality is now, they understand what I'm doing now, and they know that they can send their patients to me and they'll get the care that they need. And I even have pediatric patients for labiaplasty. I mean, the labia start to develop during puberty, and pediatricians do not counsel the moms of preteen girls. And there's a genetic component. If a mom has larger labia, a daughter might have larger labia. And I have a book out. It's called Beneath Your Pink Perfect, Everything You Ever Wanted to Know About Labiaplasty But Did Not Know to Ask. You can download it from my website. It's also on Amazon. I don't know if there's a glare, but this is what the book looks like. It's pretty and pink, and it's 40 pages. It's just a paperback. There's nothing graphic in it. And it's just very educational, and it will help you understand your body better, know what questions to ask doctors as you're consulting and trying to figure out how best to take care of yourself, and also for educating your daughters, because we need to educate our daughters. OBGYNs don't ask. Every time they put a speculum in to do a pap smear, they should be saying, does this tissue bother you? Does it get in the way? And they don't. And the number one question women ask me when I do their exam and show them their damage from childbirth is, how come my doctor didn't see that? How come my doctor didn't say anything? And I can't answer that except to say, they're not looking, they're not listening, they're just trying to do their jobs the best they can, dictated by an insurance-based system. And that's not fair to women. And women don't get the care they deserve. And that is also what makes me different, because I care and I want to give you the knowledge that you need to take the best care of yourself and know what's available.
And I think it's great that you believe in treating the whole patient, as we talked about a little while ago. And that encompasses what you touched on with weight loss, exercise, hormones. So do you have a program you put people on? And if not, what do they do?
Well, I don't have a formal program, but when I'm sitting there with the patient in front of me and we're talking about her issues, so let's say we're dealing with the incontinence and they are a few pounds overweight. So we'll start a plan, reduce your caffeine, okay? Reduce your weight by 5 to 10 pounds. Consider vaginal estrogen. Consider radio frequency. And so they can start 1 or 2, they want to wait 3 months and just start with some estrogen and some weight loss and see how that does. And caffeine reduction. Those are the big 3 right there. The other thing is, women that develop new stress incontinence should have a bladder infection ruled out. And especially as we age, because we don't have the same triad of symptoms, which is the urge to go, going more often, and the pain when we go. Sometimes we can just have an increase in leakage. And if you get a sample and you come out with a positive bladder infection, treating that bladder infection will make the leakage go away. So right away, when somebody has this, you need to evaluate and have a broader understanding, because yes, treating the whole person, treating with weight loss, treating with hormones, that can help. The same thing with orgasmic response. Okay. You have to look at the whole person. What are their hormones doing? What's their attraction? Do they have desire and arousal? There are 2 pills available for women to help stimulate the brain to want their partner. There are at least 10 for men. This is very unfair in the pharma world, okay? But that we are only limited. But the fact is that you want to make sure, and then you want to see, is your anatomy okay? Or do you have adhesions? Do you not have adhesions? How's your blood flow? So all of those things, you don't want to just look at one thing. And, when women have issues with how their body works and wanting to feel more sexual, that's the whole person. You want to make sure their thyroid's working properly if they're having a weight problem. Perimenopause and thyroid and depression can all overlap. And sometimes just giving somebody estrogen can get rid of the depression and make them feel better and treat their forgetfulness and treat their irritability. But if you have depression, headaches, weight gain, that could be thyroid. And so you want to make sure nothing is missed. So it is important to look at the whole person, to understand the age range that they're in and what's happening as they're changing over time. So even though my practice is mostly surgical now, I do have patients that come back. I recently had a patient from 2007 come back for a different procedure and wanting to get consulted again for other issues over time. And so that happens too. And that's actually a pleasure, because these women know I'm a resource for them. And that's really what I want to be, is a resource for my patients. All my patients come in, they all have my cell phone number. I'm accessible. That also makes me different from my colleagues. I want you to call me. I want to be able to answer your questions. I don't want you to sit home anxious after surgery, worrying about something when I can alleviate that. So that's just how I practice. And my OBGYN practice used to be called Complete and Compassionate OBGYN Care. And the circle with the heart in it is what represented me, for being thorough and compassionate. And that's not my logo anymore, but that is still how I practice. And for any women having issues that want to contact me, please, you can get to me through my website or Dr. Hailparn at cosmeticgyn.net.
And what percentage of your patient base now, because it's out of pocket and it's all cash, what percentage of them use care credit on a patient financing option to pay for these procedures, especially if they want to keep coming back to you on a regular basis?
Probably about half. Half will use the financing companies and the other half will pay with credit cards or cash. And we do prepayment plans as well. So we try to work with everybody. And if you combine procedures, we'll give discounts, we give professional discounts. You know, we want women to get the best results and to have what's available. So we try to work with everybody.
No, I think that's very important to be able to make things affordable to everybody. And I think that's wonderful. And a lot of people have care credit, for instance, for the veterinary or the dental or the ophthalmology. And so a lot of people already have it. And I know I looked at your website and it was great. And you also had the link on there, which was great. So that helps somebody who maybe doesn't want to talk about, you know, money issues with you.
Right.
But I guess, you know, your front desk person who is answering the phones, they should be mentioning that too, because that's, you know, a big deal. Somebody might say, oh, it's a cash base, I can't afford it. Or you're so well known, it's going to be so expensive. Are your fees comparable to the others around the nation doing it? Because I know you're doing this full time.
Yes. Also, well, the thing is that geographic location definitely affects price. So in California and New York, it's going to be more expensive than it is here in Texas, just so you know. There are definitely price variations, but we're all within a reasonable range of each other. And also, I mean, the experience is what you also are paying for. I mean, there's a handful of cosmetic plastic gynecologists in this country who have 15 years of experience, a handful. Many more of them have 5 to 10 or even less than that because it's trendy now. People want to learn it now. The problem is that doctors will take these 2 or 3 day courses and then hang out a shingle saying that they can do stuff. And it really takes a while. It takes 100 labiaplasties to really feel comfortable with the fact some contract, not all the tissues do the same thing. Everybody's anatomy is different. People want different things and they heal differently and they scar differently. And there's just so many variables. And so having extra knowledge is really helpful for getting patients through that.
So how many urogynecologists are there? Because that's a newer group of doctors that have only been, 10 years? I don't know. How long has it been?
Well, I can only tell you that the urologists, when I came to San Antonio 25 years ago, have some of them transition to Urogyn, but not a lot of them. But yes, they're kind of doing crossover. So, and they're also getting into the cosmetic plastic field as well. There's a group in Atlanta, Georgia, 2 gentlemen who definitely urogynecologists, but they're also cosmetic plastic trained and they combine everything. So, different doctors have different things to offer, but the most important thing is to make sure they have research experience, that they have extensive operating experience. And you always want to ask about risks and complications, because if anybody says, oh, they don't really have any, that really wouldn't be honest. We all have had problems over the years. That's how we learn and get better. And so you also want to know how many somebody has done. You want to see their before and after pictures. You want to read reviews. Choosing a doctor, I would always say get more than 1 consult also, because there's different knowledge that different people have to offer and different personalities. And so somebody may be very knowledgeable, but not very warm. And then you may find somebody who is warm and knowledgeable. And so you want to just see what works best and fits best for you. And yeah, when I first started, I was one of 6 in the country and I had patients coming from all over the world. Now there are at least 500 people that have the training that I have. So I'm now one of the most experienced in the country, but I'm certainly not the only female in the country or in Texas anymore. So women find me by word of mouth, by referral, by Google. And I do try very hard to do community events. Before COVID, I would do 4 times a year. I would get out there. I'd rent a private room in a restaurant. I do my PowerPoint presentation called Life-Changing Issues OB-GYNs Don't Talk About But Should. And we've talked about a lot of those today already, the leakage, the manually having to assist moving your bowels, the partner fallout, and the air due to the lack of muscles being put back at the opening. I mean, these are problems that really need to be better understood by the women who are experiencing them so that they can say to their doctors, hey, these are my problems. Can you help me?
So in the last 2 years, have you done more or have done any virtual consults? Because, people were afraid to come out. So how did you do that?
Yeah. I have actually. I've done a lot of phone consults, especially there was a 6-week period where my office was closed and I would be speaking to women probably every other day. And so I would do a phone consult. I would ask them the questions or send them the questionnaires in advance and be able to have some of that papers in my hand to review with them what they're experiencing. Of course, I know how to, which questions need to ask to help focus and figure out what their concerns are. And usually by 30 to 45 minutes after a conversation, they know that either I can help them or I can't help them. And I will be right up front if I don't think I can help somebody either. Or if somebody's had trauma, and I recommend most people who've had trauma that come to me have a therapist already established so that if they have any post-traumatic stress that occurs post-op, they have a support person besides me. Women are very complicated. We need a team. And the surgeon cannot be the psychologist. And even though we try, really we need a team. And so really that's my approach as well. So my patient coordinator is Meg. And so I try to keep the money separate from the medicine. So she does all the financing, she does scheduling, she helps with the payment plans, and she's the one to have most of the discussions on the money aspect with the patients when they come in.
That's interesting because one of the things that I often talk about every day on the phone with potential clients or clients is the staff. Now, when you went from, just thinking about it, from your insurance to cash, did you have to change your staff?
Well, a little bit, I did. And over time, so I used to have a very large OB-GYN practice. I didn't need all that staff when I changed to a smaller cosmetic plastic practice. And certainly at the beginning, it's much smaller because you may have OB-GYN patients who are interested within your practice, what you do, but because they're insurance-based, many of them don't have the money and can't afford or don't want to pay out of pocket for procedures. And it's almost a different clientele. So having a cash-based practice, these women come in understanding, most of them, that we don't use insurance. Now, what I will try and do, if somebody's had chronic labial pain for years and they're 17 or they're 20, and we can get a pediatrician to write a referral letter to me because I do this surgery, that can be used to help insurance cover a procedure. So if you can document chronic pain, getting those referral letters to me can help get reimbursement for the patient. But that is between the patient and their insurance company because we are not contracted. I will write a letter of medical necessity and I will do appeal phone calls for patients, which is over and above what paid physicians will do. But I want my patients to get the help they need any way I can. And so if I can help, I will. But it's really important to understand that if you go to your OB-GYN and you say, I can't feel my partner, they're not going to do a back wall surgery on you to fix that. It's only if you go and say, I'm having trouble moving my bowels or my bladder's not working, will they then operate on you? And they won't take sexual function into account either. And that's a problem because not all vagina openings should be brought back to the same size. There's a range of partner sizes. And so don't laugh, but I ask my patients to get a partner girth measurement. I don't care how long they are, that's not going to impact. But the doorway cannot be the same for everybody. If you have a partner that's 1.5 inches versus 5.5, you can't make the doorway the same. And it's not an exact thing. It's just to make sure that he can get the head in the door, because post-op, if it's too tight, it's not good. And there are women that come and say, make me as tight as you can. And they don't recognize that anatomically, you want to be re-supported appropriately. And so that's really important. And you also want to make sure that they're going to do the inside and the doorway when they're doing the vaginal reconstruction, not just the inside or not just the doorway. There are many women who've been misled and paid money for vaginoplasty or vaginal reconstruction surgery and not gotten the full package and have come to me for second surgeries because they didn't get everything they needed or they weren't successful. So.
Where are you doing most of your surgeries? You have a surgery suite in your office?
I do not, because that requires a lot of regulations. I have several outpatient facilities that are very close to my office that are wonderful. They're accredited. I have specific anesthesiologists who come with me on a regular basis, who are also wonderful. And my surgeries take 1 to 3 hours for the most part. You know, labiaplasty takes an hour. A vaginal tightening procedure takes an hour. If you combine, it takes 2 to 2.5 hours. If you have hood in addition, it can add another 30 minutes, but they're all under 4 hours, which is what's considered. You don't want to go over 4 hours for elective procedures, even though they're fixing functional issues. So I try to stay within those guidelines. And with me, I have certain things that I do to reduce infection risk. My infection risk is almost none. I have them wash with antibacterial soap the week before, anti-staph ointment they use for their nose. They get 1 dose of antibiotics. And post-op, I use Dermaplast spray, which is both antiseptic and anti-pain. So my infection rate is almost none. I have really good pain management. My patients get 10 pages of pre and post-op instructions because I like to leave nothing unturned. All your questions get answered. You have my card to call me if there's something missed. So we try to be very thorough with our patient care from the minute they walk in the door until they're healed and on their way.
Well, this is definitely life-changing for a lot of women. And I thank you, Dr. Hailparn, because this was amazing. And I've learned a lot. There's so many key takeaways, but maybe you want to offer a couple of just quick takeaways to anybody that's listening today.
Well, if your body has changed from childbirth, please know they're not normal consequences. Put a big red game show X through the word normal. You didn't have them before childbirth. You have them after. They're problems for you. Talk to your doctor. And if your doctor's not responsive, look for somebody else who is. That would be number one. And same thing with labial issues. If you're living with tissue that's causing you irritation and discomfort, or it's just enlarged and unattractive to you and impacting your social life, please know that there are doctors that can help you. And look online, research, get more than one consult, and find the right person to help you. That would be my advice.
And I thank you so much. Tell us again on Amazon. I guess we could just put your name in to look for your books.
Yes, and you can go right to my website, cosmeticgyn.net, and you can download the book right from the website. It's Beneath Your Pink Perfect. Beneath Your Pink Perfect. Everything you ever wanted to know about labiaplasty, but didn't know to ask.
Well, thank you. And I hope that people listening today will buy it because it is life-changing.
Well, it's free on the website. They don't have to buy it off the website.
Oh, that's great.
Yep.
I think, and I think we should talk about, your programs at another date, because there are so many doctors and providers out there that would like to learn more from somebody like yourself. Being that you do the non-surgical as well as the surgical, there's a lot of nurse practitioners out there, and there's a lot of people who are not going to necessarily do surgery, but are very interested in helping women. And I think they can learn. I know they could learn a lot from you. So I thank you for today. And I look forward to having you again, and we could talk about some other subjects, but it was great having you and very educational and informational.
Well, thank you so much for inviting me. I really appreciate it. I love educating women, and I really thank you for the opportunity. And I do look forward to the next time.
Okay, good. I do too. Well, thank you. And that was wonderful, great information and education for all of us. We do always have handouts at all of our webinars. So the art of selling and an educational twist is very important. It's all about education, as we've even been talking about today on another level. So we're happy to send the download to you, and it's free for signing up today. And we look forward to hearing from you on some topics that you would like us to be interviewing and having conversations with. We do have a complimentary session we're happy to do to help you to be successful and to grow your practice, or to start a practice, whether you're a single provider, hospital size. We work with every size. And we always have tips to be more successful in your practice. So the book, Beautifully Profitable, is in its 6th edition. So we have the ebook version, with the discount code on our website, Profit. And I wish you all good luck, and I hope to hear from all of you soon. And have a great evening.